A very good morning to all. Today I'll be taking another topic from Recent Advances, but this is Recent Advances third edition of Hematology topic. This is Approach to Polycythemia. So today we'll be discussing about the classification of erythrocytosis, evaluation of erythrocytosis, congenital erythrocytosis, polycythemia vera, and acquired erythrocytosis. Why I'm using the term erythrocytosis, I hope you people know because erythro means red blood cell related, red as such, and then cyto means cells, and then red blood cells. So erythrocyte means red blood cell, and cytosis. The osis is something which we use when there is increase in the count. Like leukocytosis means increased WBC, thrombocytosis means increased platelets. So erythrocytosis is obviously increased RBC. So polycythemia is also a term which is used in the same way. And so to understand this concept, we should also know about this diagram which I showed, that is normal blood. If we keep it in a test tube for settling, the RBCs will settle down. That is how we take the ESR, which is the plasma which is present above. So anyway, leave about the ESR. When we keep an normal blood for settling for some time, so you will see that RBCs will settle downwards, and then you can see there is a buffy coat region which is formed between the plasma and RBCs, which consists of WBCs and platelets and maybe parasites, etc. So this is how a normal blood sample you get. So if the patient is having anemia, obviously the RBCs are decreased, so you will get there is more plasma, like kind of you will feel there is more plasma, but there is RBC is decreased actually. And then in polycythemia, on the contrary, the RBCs are increased, but the plasma is decreased, you will feel. Okay. So here as such, you will see the RBC content is decreased and increased, etc. So what is polycythemia? Ideally, it is a group of disorders with raised circulating red blood cells. Okay, so there is increase in the RBC count. So the term erythrocytosis is the one which is actually preferred because polycythemia usually we use it for telling polycythemia vera, which is a clonal disorder. Okay, so polycythemia we use ideally to tell about PV itself. So for throughout the topic, we will be now discussing it as erythrocytosis itself. So erythrocytosis also can be secondary or primary. Okay, primary erythrocytosis is the one which is by genetic mutation. There is increase in the RBCs because the RBC precursor had a mutation. That is, hematopoietic precursor cell had a clonal disorder or mutation because of which RBC is increased. So that is primary erythrocytosis. Secondary erythrocytosis is conditions in which erythropoietin production, that is the protein or hormone which is produced by the kidney, and because of that hormonal increase or that protein is increased, the erythrocytosis is increased. Okay, so that is secondary erythrocytosis. There are many conditions in which there is secondary erythrocytosis, but there is no clonal disorder in the hematopoietic precursor as such. Okay, so it is important to diagnose polycythemia vera because it is a highly morbid and mortal condition. Then nextly we tell about the classification of erythrocytosis. As I said, first you have to distinguish whether it is true erythrocytosis. Okay. So there is apparent erythrocytosis, or you call it as relative erythrocytosis, in which because of dehydration the plasma volume is reduced. Because of that we will feel that the RBC count is increased. So in the first picture I had shown a picture of normal volume, and and then the RBC settled down. So you can imagine that anemia was a condition in which RBCs were decreased, so you felt there is more plasma in it. Okay, so in the same way, there might be decreased when the RBC count is increased, there is decreased plasma volume also. But this decrease in plasma volume can be also due to because there is dehydration in the body, or water content itself is reduced. So ideally plasma is decreased, but the RBC content is the same as such. So in such conditions, you call it as relative erythrocytosis because actually the plasma was decreased and RBC count was remaining the same itself. Okay. And then, so if I actually there is true erythrocytosis, then it is divided into two, that is primary and secondary. Other thing which I have to say is that the hematocrit also. So hematocrit is the parameter by which we mainly diagnose polycythemia and erythrocytosis, etc. So this hematocrit also in dehydration conditions it can increase. So it is important to rule out relative erythrocytosis in the first stage itself. Then we know there is true increase in RBC or red cell mass. Then you can differentiate, you should differentiate whether it is secondary, as I said, by increased erythropoietin production or by primary clonal disorder, which is seen in polycythemia vera. So, secondary erythrocytosis, the conditions are usually it can be congenital and it can be acquired as well. Congenital means usually it is seen in very young age itself, and which are seen in adult or which appear in the adult stage. They, and due to other cancerous conditions, etc., they are called as acquired erythrocytosis. Okay. So secondary erythrocytosis can be due to high altitude also, that is where there is hypoxia. So in those conditions, because oxygen content is reduced in high altitude regions, there is increased RBC production to compensate for to take more oxygen which is available. Okay. So that is a adaptive mechanism of the body. In the same way, when there is hypoxia in the body, whether it is like due to cardiac problems or due to lung problems, because you need proper lung to take in oxygen, and the blood vessels also should be proper, that is vascular system or that is cardiovascular system should be proper for the oxygen to be absorbed into the blood also after taking from the lung. So you need proper lung, respiratory as well as cardiovascular system to have a proper oxygenation. So any of these diseases can cause peripheral hypoxia or central hypoxia, and because of that also, to compensate for that, body will increase erythropoietin production and then there will be increase in the RBC. So that is how it is. How there is secondary erythrocytosis. Other causes of increased EPO production can be even tumor conditions like hepatocellular carcinoma, renal cell carcinoma, cerebellar hemangioblastoma, uterine leiomyoma, pheochromocytoma, etc. These tumors have a predilection and the proteins that can, and they can cause increase in erythropoietin production, and because of that there can be secondary erythrocytosis. Okay. So we found it is primary or secondary. So now how are we going to evaluate a case of erythrocytosis? Firstly, how we are going to tell it is erythrocytosis when hematocrit is more than 51 for males or 48 for females, then we have to consider the case as erythrocytosis or bring it into attention. And then first you have to confirm it is true erythrocytosis, that is the patient is not having dehydration or something like relative erythrocytosis. Ideally the red cell mass count is increased. Then if you have found it is erythrocytosis, you have to distinguish it between primary or secondary. And then for looking into etiology, you can divide it into congenital or acquired. So congenital erythrocytosis, that is erythrocytosis that is present in young age, or if there is a family history for a patient of malignancy, etc., that time you can get erythrocytosis. Okay. And then you have to take the history properly, because if the patient is already living in a high altitude condition, or he is having a cardiac disease or lung disease, or from how much since he is having any hypoxic conditions like cyanosis, etc., with this. So all these are important for a patient who is having erythrocytosis. Okay. It's not like directly a patient comes with hematocrit, you should go to test for JAK2 mutation. Okay. First test, which is the easiest, is you have to do CBC, obviously. Then you will check for the hematocrit is increased, and then hemoglobin you will check. You will check for the RBC mass. red cell mass, you will check, and then you will come, then you will see, think about the condition that the patient is having erythrocytosis. Then you have to go for EPO level, that is erythropoietin level. You have to check whether it is decreased or increased or normal. Okay. In polycythemia vera, usually it is decreased or normal because already there is so much of RBC production. Then why should the erythropoietin level be increased? By the feedback mechanism, it will be decreased also. So in polycythemia, EPO will be decreased, and in main all other conditions, it will be normal or higher. Okay. So low EPO level can also be due to VHL mutation. It is also called Chuvash polycythemia because it was seen in a Chuvash region in Russia. Okay, so if there is any mutation like VHL mutation, PHD2 mutation, HIF2A mutation, in these conditions also there can be low EPO level that I will explain. And then high or normal EPO level, normal oxygen affinity like in erythropoietin receptor mutation. Okay, so if the receptor is mutated, the receptor will already keep on giving the signal, and because of that signaling, there will be increased EPO level. Okay, here affinity of hemoglobin, there is no connection. Hemoglobin is fine only and normal, but the erythropoietin receptor mutation is there, and because of that, there is increased EPO production, and because of that, there is erythrocytosis. High oxygen affinity hemoglobin. See here, the hemoglobin oxygen affinity was normal. Here, there is high oxygen affinity of hemoglobin. Why? Because there is high oxygen affinity hemoglobinopathy. Okay, so there are some hemoglobins like methemoglobin, etc. I will be explaining now in the next slide. In there you can get high or normal EPO. Okay. So see, as I said in the first condition, when there is low EPO level, so what is happening is there the VHL protein, HIF2A protein or PHD protein. Okay. Usually these three proteins normally they stay combine and make a complex, and then they get degraded by proteasome ubiquitinase mechanism. Okay, so when they are not degraded, the HIFA signalizes the nucleus, and then it causes EPO production, and there will be increased EPO. Okay, so suppose if there is EPO and maybe some other proteins also they will target, and because of all those targets there will be increased erythrocytosis. So that happens especially when there is hypoxia. So when there is any mutation in these things, no, these proteins doesn't form a complex, and then they doesn't get degraded by the proteasome ubiquitinase. And other than that, they will constitutionally they will be activating the nuclear protein, and then they will cause activation, and then they will cause increase in erythrocytosis. So that can be by EPO and other proteins also. When so every other proteins also, when it is stimulating, the EPO level is decreased because there is already erythrocytosis in this condition. And then I said there is EPO level can be high because of the hemoglobinopathy, that is high oxygen affinity hemoglobinopathy, that is methemoglobin, carboxyhemoglobin, fetal hemoglobin, etc. You know, they have high affinity to oxygen. So when there is high affinity, they take the oxygen but they don't leave it out. That is, they won't release it into the tissue. They just absorb it from the lungs, but they catch it and they don't give it to the tissues. That is what is the function of the hemoglobin, to take from the lungs and then give it to the tissues where it is required for mitochondrial energy production. So but here what happens when these type of hemoglobins, that is high oxygen affinity hemoglobin, is increased in the blood, there is left shift of the oxygen dissociation curve, and there is high affinity but there is decreased unloading, or tissues doesn't get, so that causes a hypoxic condition. So when in hypoxia is there, obviously there will be increased erythropoietin, and then because of that there will be erythrocytosis. Other condition is when there is 2,3-DPG. When 2,3-DPG the mutation is occurred, usually when 2,3-DPG is there, they has decreased affinity, and then they will cause low affinity or low oxygen affinity hemoglobin. Okay, so they won't catch the hemoglobin oxygen and keep, and tissues will get more oxygen. But what will happen if there is 2,3-DPG mutation to the receptor? sometimes, then the curve will shift to the left. So the scenario will be opposite. So then we will come now discuss to polycythemia vera. So polycythemia vera in this, so it is a clonal disorder. It is a clonal disorder of multipotent hematopoietic progenitor cell, okay, affecting three cell lineages. This is very important, okay. It is not only the erythrocytic precursor. What are the erythrocytic precursors? They are the normoblasts, which we study, orthonomic, polychromic, etc. When reticulocyte is also a precursor. So it is not the RBC precursor as such which is affected. It is the multipotent hematopoietic progenitor. That is the progenitor which is going to give rise to all the cell lineages, that is thrombocytes, leukocytes, and erythrocytes. So the precursor of all the three. So there is a clonal disorder there. So when there is a clonal disorder there, all the three cell lineages can be affected, and it can be increased also. That is, there can be increase in WBC, platelets, and everything. But the predominant manifestation is erythrocytosis. Okay, but ideally three cell lineages are affected. So that is why it is called myeloproliferative neoplasm. It is a chronic myeloproliferative neoplasm because there is myeloproliferation. All the three cell lineages are increasing, and it is a clonal disorder, so it is neoplastic, and it is chronic because it is there for long period of time. It is usually affecting 50 to 60 year age group, and then there are two phases to it, that is initial proliferative polycythemic phase and second is spend or post polycythemic phase, okay. So most of the pyeloproliferative disorders, if you are studying, you will see first there will be the proliferative phase for anything, mainly CML and myelofibrosis, essential thrombocythemia, and then polycythemia vera. All these are chronic myeloproliferative disorders. All these have the initial hypercellular stage of the or proliferative stage of the bone marrow, where there is increased production of everything. And after a stage, there is a spent phase. That is almost it goes into fibrosis. So all the myeloproliferative, most of the myeloproliferative neoplasms after the initial hyperproliferative phase, they just go into the fibrotic phase, myelofibrotic phase, okay. So that is basically common to all myeloproliferative neoplasms. So here also initially there is proliferative polycythemic phase in which all the three cell lineages are increasing, but especially absolute erythrocytosis is characteristic. That is why we call it as polycythemia vera. And spend or post polycythemic phase, in that you will see cytopenia because it is marrow is undergoing fibrosis, so there is no much cell production, so the cell counts will decrease. There is ineffective hematopoiesis, that can be also due to decreased production or maybe increased degradation of the cells because they are defective also, the hematopoietic precursors. And then as I said, there will be bone marrow fibrosis. Then there will be extramedullary hematopoiesis, that is there will be increased production of the blood cells from extramedullary site other than the bone marrow, that is in liver, spleen, etc. And then there will be hypersplenism also. And then more than 95% of the cases, it is found that there is JAK2V617F mutation. Okay, this mutation can be also seen in other myeloproliferative neoplasms like my myelofibrosis, essential thrombocythemia also to a certain extent, I guess. But then in 95% of the cases, if you're not getting this, we are not getting this mutation, then to a small percentage, we should also try to check for JAK2 exon 12 mutation. Okay, so these two are the main mutations in which you will get polycythemia vera, which is confirmation test. And then other thing which you should remember is polycythemia with negative JAK2 mutation is also very, very, very rare. Okay, so all either of these two mutations will obviously there. So according to WHO criteria, major criteria may you will have hemoglobin which is more than 18.5 for men or 16.5 for women. Okay, or else the rest of the thing, baseline thing and all. Anyways, you have to remember it is HB is 18.5 cutoff for males, and for females it is 16.5. More than that, you have to think about erythrocytosis and polycythemia especially, and then hematocrit should be more than 99 percentile. Okay, and then there should be presence of JAK2V617F mutation or JAK2 exon 12 mutation. That is a major criteria, but it is not a very essential thing. Okay, see, if you either have two major criteria and one minor, or you should have the first major and two minor criteria. Okay, if you couldn't get to do the mutation testing also, you can tell it by bone marrow biopsy and EPO level also. So if bone marrow biopsy shows hypercellular, if it is in the first stage, then you will get prominent erythroid, granulocytic, megakaryocytic, all the three cell lineage proliferation. And if it is in the spend phase, then you might get myelofibrosis as well. And then, but the criteria is about hypercellular bone marrow. And then serum EPO level will be obviously decreased. And then endogenous erythroid colony formation in vitro also can be used as a test. Okay, so these are the criteria. So two major and one minor should be there, or either first major one and two minor should be there. So lab evaluation, there are primary investigations and secondary investigations. Primary investigations are the one which you have to do to diagnose the case. Okay. So obviously you will do CBC. So you will see there is increased red blood cell count. Then there is neutrophilia is also seen, and in many cases you can also see basophilia also. Okay. So this basophilia is, doesn't mean that it is obviously CML cases in which you will get basophilia. In polycythemia vera also you can get basophilia. And arterial oxygen saturation is tested because if it is less than 92%, it is more showing towards hypoxia. But in polycythemia, actually arterial oxygen saturation should be normal because it is a defect of RBC production and not because of hypoxia. Serum EPO level, as I discussed, will be reduced. Serum ferritin also will be reduced to certain extent because of the feedback mechanism, because there is already so much of RBC. So there is a feedback mechanism by which ferritin has decreased. And then you will do RFT, LFT to check for any liver or renal pathology like RCC, HCC, or any other derangements are there. Then you have to think about other causes of secondary erythrocytosis. Abdominal USG and chest X-ray to check for any lung diseases, or you have to check for any tumors like uterine leiomyoma, RCC, HCC, etc. Then secondary investigations, I said for the criteria to fulfill, you have to check for bone marrow aspiration biopsy, in which it can be in the first stage it will be hypercellular, and then the second stage there will be fibrosis. And cytogenetics, you can get trisomy 8, 9 or deletion of 20q, 30q or 1p. And then culture test you can do by using burst forming unit of the erythrocyte culture. So when these cells, that is burst forming unit erythrocytes, that are precursor cells which you will be using it for culture. So these erythroblasts, when you are putting it in a culture, they do not require EPO because of the mutation that is already there in polycythemia cells. Okay, because usually in normal state they require erythropoietin for the culture to grow more RBCs. But in this polycythemic cells, you don't require EPO, and then still the culture will be positive. Then you will check for JAK2 mutation, which is commonly done to check for polycythemia. And then other tests are oxygen dissociation curve, as I said, to see whether there is secondary causes of erythrocytosis other than PV. And then you will do sleep studies to check whether there is sleep apnea, which is causing obstruction and hypoxia to the airway. And then lung function test to check for any oxygenation problems or lung problems. Erythropoietin receptor gene mutation to check whether there is gene mutation, because of that there is increased erythropoietin level and which is causing erythrocytosis. So these are mainly to rule out the other causes and to confirm that is polycythemia itself. Clinical features wise, there can be thrombosis because there is increased RBCs, and because of that there is increased viscosity to the blood. Okay, so because of the increased viscosity, as you say, studied in Virchow's triad, you can get thrombosis because blood is flowing less, so you will get more chances of clot formation. So there can be arterial or venous thrombosis. There can be hemorrhage as well. Okay, so if you think there is so many thrombosis already occurred, and then now the RBCs and platelets are all clumped into the thrombus, now then you can get hemorrhage also, because platelets are decreased now. It's like something like a DAC kind of mechanism. So you can get hemorrhage also. Pruritus is there, which is aquagenic, which is mainly because of the even erythromyalgia, that is red burning toes, feet, and fingers, especially when you bath in hot water. You ideally ask the symptom to polycythemic patients, like, do you bath in hot water and you feel really very itchy and painful? So that is erythromelalgia. So why that occurs is because of the histamine production in the skin, because of this mutation that occurs. Okay. Then there can be hepatomegaly, splenomegaly, which is in the spent phase. There will be extramedullary hematopoiesis. And then peptic ulcer, that is also mainly because there is increased histamine production and all. Hyperuricemia, gout, any proliferative disorders or neoplasms, when there is excess of cell division, there will be increased purine pyrimidine metabolism, and because of that uric acid will be formed, and because of that hyperuricemia can be there and gout can occur. Then you can get secondary acute leukemia, myeloid metaplasia, etc., because there is mutation already happening, and there is cancer which is progressing. So when there is additional mutations that occur, the patient can get or transformed into acute leukemia, myelodysplastic syndrome, myelofibrosis, etc. So all the myeloproliferative neoplasms can go into acute leukemia, myelofibrosis, etc. So management wise, we do the management mainly to decrease the risk of thrombosis and hemorrhage. Because of one thrombus also you can get myocardial infarction, extensive hemorrhage like peptic ulcer, and many hemorrhages can cause into hemorrhagic shock, etc. So mainly it is to control the thrombosis and hemorrhage risks, and then manage the complications of the polycythemia. And then so we do venous section to keep the hematocrit less than 45. You can give low dose aspirin, which is an antiplatelet, to prevent thrombosis, which is 75 milligram per day. And then you will obviously discourage smoking, because smoking can cause increased tendency to form thrombus. Choice of cytoreductive therapy. Cytoreductive therapy means there is a neoplasm which is going, it is like a chemotherapy, how to decrease the production of the cells, or how to decrease the cell division. For that, you can use according to the age wise. Less than 40 years, the first line of treatment is interferon alpha. 40 to 75 years, you go for hydroxyurea. More than 75 years, also first line treatment is hydroxyurea, or otherwise you can use radioactive phosphorus 32 or intermittent low dose busulfan. Other second line drugs are analgyride also, okay, which is used to mainly to curb the thrombocytosis. It is second line drug, because you cannot you these things are not affecting the patient, then only you will go for those drugs. 2 year survival rate is less than 50% if it is not treated well. So you know how much morbid the condition is, and there is a chance, as I said, to all myeloproliferative neoplasms, it can get converted into secondary leukemia, myelofibrosis, myelodysplasia, etc. So lastly, we will be discussing about acquired erythrocytosis. Okay, acquired erythrocytosis, as I said, it is like it can be manifested late. Okay, so acquired erythrocytosis is like polycythemia. It's not like it is obviously congenital. The mutation is there for the patient, but then it can be presented later also. So then we consider it as, you should consider it as a DD for acquired erythrocytosis as well. So we will check obviously for EPO level, etc. So we will in this flow chart accordingly, if there is raised hemoglobin, we'll go for JAK2 V617F mutation. If it is positive, then you will check for other features which will, if there is erythrocytosis and other features are consistent, then you have to think of polycythemia, because I said this mutation is also there for primary myelofibrosis and other conditions as well. So this is obviously you have to correlate with the criteria of polycythemia of two major and one minor, etc. and all. Then only you will confirm this case. And if it is negative, then you will go for the other mutation, that is JAK2 exon 12. It is positive, then obviously should be polycythemia. If it is negative, then you are thinking about secondary erythrocytosis causes. So EPO level you will do, you will check whether it is high or low, and then you will differentiate the other erythrocytosis causes. So we come to the end of this discussion. Hope it was helpful. And then this is topic taken from Recent Advances, third edition of Hematology. And I extend my mm, gratitude to Manoranjan Mahapatra and respected Shyam Rati for contributing this beautiful article to the Recent Advances. Thank you.